severe, but in the labs, the cases are increasing. So this is a lull before the storm. This is exactly what happened second time also.
Correct, yeah, exactly, yeah.
No, the government of India advisory has come, sir. That's what I'm telling you yesterday.
Oh.
This is based on the number of cases in labs all over the country. So there is a increase now rather than decrease. So this is how it will explode suddenly. So that's why we have to be.
So we have to be extra careful now.
We have to be careful at least for a month or so. If it does not increase, then probably it is, the trend has to be there. So Madhu, you will send me that apraxia video?
Yeah, I already kept it ready. Today evening I will send it to you.
And you have to also, you can either call me at the time that what it is showing, that's all.
Yeah, definitely.
Yeah.
Okay. Yeah, definitely I will write everything in that. And
that I can put it in my PowerPoint, no? That is easily.
Definitely you can put in the PowerPoint.
Yeah.
I have edited in that video in the broadcasting format, and then I will send everything.
I always show one of your videos of aphasia, global aphasia.
Yeah, that one, Nick is a grace. Yeah. With the logo, yeah.
So now I will be showing your videos of apraxia also. But you must be having thousands of videos, no? I think below every video we should say courtesy Madhu.
That you need not put, just project as it is.
But this is called passion. Now this medical teaching or neurology teaching is your passion now. I mean, it has taken proportion of passion. It is no longer normal now. It is beyond normal. It's passion. Therefore, what I'm saying is the moment patient must be entering your cabin, you must be thinking, can I show it or not? And you must be because what used to happen is that when I used to collect stroke data for about 10-15 years, I have collected only stroke data. So the moment this stroke patient used to enter, the first thing I used to think, have I filled the form or not? On the other hand, when cervical spondylosis would come, I would listen to them. Or if a motor neuron, I would think. But when a stroke patient would come, first thing I would think, where is my form? Have I filled the data or not?
Are you doing the same thing now also?
Yeah, now also, because in the private hospital where I joined, they made me in charge research. The problem is that when your reputation walks with you, wherever you will go, you can never change your reality. So suddenly they said you are chairman of the research and all. So now you have to make some. So now we are working on some other research project, transcranial magnetic stimulation in stroke and all that thing. But I'm not collecting data the way I used to collect those days. That was very feverish. That proformas and all that thing. Now that is the time of your life. But your thing is very good, because yours is it's clinical, so it's very interesting. But it must be taking some time, Madhu, I'm very sure.
Yeah, it takes a lot of time for editing.
Normally if you can see a patient, your whole interaction with patient would be 10 minutes or 15 minutes. Once it is like this, it will extra 10 minutes, it will definitely.
Definitely extra 10 minutes. And subsequently I have to edit the video, the people will be talking in between, somebody is coming in between. So those things has to be cut off.
Even if you have to look at a MRI carefully of a patient who comes with a MRI, if you have to look at it carefully, it will mean another 10-15 minutes. And but for that you have an advantage, you have your son-in-law. That everybody doesn't. Time is at premium in these OPDs, because patients are waiting outside.
Right.
Then that person comes, sir, patients are waiting, sir. So therefore, Madhu, what you are doing is, I highly appreciate it. I know it is a challenge, There's a lot of hard work behind it. We just enjoy every Sunday morning over coffee, but I know how much of hard work is there. So I think we have already crossed 9 o'clock. You can start probably.
Okay, I'll start. So, good morning, everyone. I think this is the 49th session on this challenging case series. I will start my screen. Is my screen visible?
Yeah, Madhu, it's visible. Make it big screen.
Okay, right. This is the follow-up of the last week or 2 weeks back. I showed one case of suspected myoclonic dystonia. This is the follow-up of that. I just show the case once again. It won't take more than 2-3 minutes time. This girl had come with tremor on the right side of the body for the last 9 years. These tremor-like movements were not present all the time, and was more while writing and bringing it from a cup. She had occasionally dropped things from her right hand. This is the video, just show the important part of the video.
Yeah.
Skip all those things. I'll go to the main part time.
See that.
This is the point.
Don't write it.
Used to jerky movements while writing and dystonic posture with the right hand. The neck and hand goes into jerky movement. I'll show another video where there is you can more find out the
Do it like this. Okay, touch my finger and nose.
actually the neck connecting jerk of the head.
Use this hand,
Exactly.
this side.
This will be a little more better clearly seen here. Clearly observe the neck. Suddenly, yes. That's a jerk. That 1 second. That's a jerk. The diagnosis made was at that time, and her writing is also affected severely. That's a jerk. So we thought of the possibility of a myoclonic dystonia. So the gene testing came last week, and that showed this myoclonic dystonia 11 that confirmed the diagnosis. Her father also had this kind of jerky movements. This has been there for the last 10 years without much population. Okay, I'll go to the case now. As usual, for the short case first. This 62-year-old man had presented with
Madhu, sorry to interrupt you.
Yeah, sure.
I was just thinking of that myoclonic dystonia. So, her father had the same thing.
Yeah.
But suppose if the father did not have this, would you still clinically think of it genetically?
Still a myoclonic dystonia itself.
Of a genetic. Is it
Yeah.
mostly genetic only? Is that the commonest? Because we get so many of these patients, no? Who
Right.
come with. So is genetic the most important cause?
I think so. I also see many of the cases sporadic without any family history, but we are not really investigated them for a genetic testing.
And would it be applicable to the entire spectrum of dystonias at that age, including writer's cramp?
No, they can present like this lady had not only writer's cramp, also got dystonia of the neck also occasionally.
Yeah. So in all of them, we should do a genetic test. Is the message?
Ideally, yes.
Okay. Okay, boss. Okay, so just for clarification. Thank you, sir. Please go ahead, sir.
He came with the history of binocular diplopia, mainly on looking to the right side for the last 2 months. No headache, not a diabetic. It's a very short case. It's the ocular movements. Suspicious restriction to the right side. Orbicularis is locally normal. That's all the finding. Here I'll show the first part once again. On to the right side. That's all. But he complained of diplopia to the right side. Now this is the patient here on looking to the right side. Okay, what do you want now in this patient? MRI, obviously, no? So later on, so this is the MRI of the patient. The brain, flare sequences, normal. So what else you need now? Everyone can voice out, please.
So can you tell the history once again?
He complains of diplopia looking to the right side, binocular diplopia, for the last 2 months. He's 62-year-old, not a diabetic, and no pain in the eye.
Sir, in the video, sir, head is tilted to the right side, but ocular movements appears normal, sir.
It appears, grossly appears normal. Correct, you are perfectly right. If you look, one look, it appears normal, but he did combine now diplopia and look into the right side.
Right.
So there may be a mild restriction of the left adduction or right abduction.
Yes, sir.
Sir, any diurnal fluctuation?
No diurnal fluctuation. He say, no, in fact, he is telling it's only on looking to the right side. So that part, diurnal fluctuation, he said sometimes it is there, sometimes it's not there. Not particularly towards the evening.
Can do an
Can do the
alternate cover
acetabular
test.
Pardon? Yeah, but there is cover and cover I did not do. I thought there was mild restriction. So I took it as a lateral rectus weakness.
Has he got headache?
No headache. No headache, no fever, no pain in the eye.
acetylcholine receptor antibodies.
Okay. So before that, shall we do an RNS?
Sir, visual acuity is normal, sir. Both eyes.
Normal. Visual acuity is all normal.
Okay.
So RNS was done. This is the RNS. It's negative. Now what else you need?
Neostigmine test. And,
But the problem with neurostigmine test is that that weakness is so subtle that a positive response will be difficult to check. If you have got ptosis and all, easy to find out. Mild restriction will be difficult to find because diplopia is not present all the time. Only one extreme is telling diplopia. So sometimes improving again, we are not very certain about it.
maybe you can try treatment with pylostigmine for some time.
Okay, your what all thought was correct, which is not correct. In fact, I took a CT, I mean, X-ray chest. Because the time of the Myasthenia was in my mind. So it showed a thymic swelling. This is the thymic swelling. And thymectomy was done and the biopsy came as thymoma. It was put on pyridostigmine and follow-up after 6 months is totally asymptomatic. Just to bring out the case that even in older age group with diplopia and with any other test negative, you have to keep this possibility in the back of the mind. It's not a fantastic case, but I thought I'll present this one.
Sir, anti-acetylcholine receptor antibodies.
Antibody was negative.
Yes, sir.
Okay.
Sir,
That patient again. So that patient again. Sorry.
Pardon?
That patient could be considered the commonest cause, as you used to mention, of that non-paralytic spin which manifests now.
Yeah, that can be considered as a possibility if everything is lost only late onset 2 months. You have to keep that. You can keep that possibility, of course, if everything is negative.
Sir, what symptoms or sign made you to think of thymoma, sir, in this patient?
No, nothing.
Particular, sir.
As you're all suspecting, I also thought one possibility of myasthenia. I thought it will not be going to be fruitful in this patient unless there's a definite paralysis. You can't make out the correction with the new statement. So therefore, the other antibody was tested and also CT test, X-ray test.
Sir, in this case, was there any fatigue phenomena or?
Nothing, because so in fact, ocular movement grossly appears normal itself.
Yeah.
So it's very difficult to check the mild restriction. You can see the ocular movement. Very, very minimal, subtle, questionable weakness. But symptom was there.
So does this mean that for every patient with, if we suspect myasthenia, we should rule out the chest imaging? Like all the other tests were like, we could not get the confirmation of myasthenia. Only chest X-ray was this thing.
As you said correctly, we came myasthenia, we do the certain tests are routine. Acetylcholine receptor antibody, RNS testing, ISPAT testing, neostigmine. These are all we'll do. But in this case, it is so subtle, we can't do this test properly. And whatever test we have done was negative. That's why every patient should go for a CT test or X-ray test.
Okay.
Now I'll go to not very difficult, but not that uncommon, but interesting case. A 70-year-old man, he was noticed a reading problem, but no visual problem. He cannot read, that's only complaint in this patient. In fact, this happened 2 weeks back. Prior to that, he had severe headache on the left side. And this case was from Pushpati Hospital, where I was at that time working in. Now look at the way he is writing. I'll go show one finding after another I will show. Able to ask him to write.
Presently, I am admitted in Pushpagiri Hospital.
Admitted in
Pushpagiri Hospital.
Pushpagiri Hospital.
And then he was asked to read what is written. Cannot read even a letter.
PN.
PP.
Struggling to find out letter.
Presently,
പറഞ്ഞപ്പം കിട്ടും PRESENTLE presently I am at അല്ലല്ലോ I am
So he could not read. So show the letters now.
ഇത് അക്ഷരമായിട്ട് വായിക്കണം. അപ്പോൾ C
but he could not read.
M
ഇത്
ഇത് M അല്ലേ? കവ മലയാള ഭാഷയാണ്.
മലയാളമാണോ?
അല്ല
He's telling it in Malayalam, not English. Yes.
ശരി, ഇനി ഒരു കാര്യം ചെയ്യാമേ. ഇവിടെ ഇംഗ്ലീഷിൽ എഴുതണം. കീ എഴുതണം. കീ നമ്മൾ ചാവിയില്ലേ, കീ എഴുതിക്കോളൂ. വെരി ഗുഡ്. അതിന്റെ താഴെ കാറ്റ്, പൂച്ച. വെരി ഗുഡ്.
So what is he having now? It's the case of dyslexia
without agraphia.
Yeah. So this is a condition where patient cannot read. Other functions like naming, repetition, comprehension, fluency are all intact, and writing is also intact. Well, let us see what does this video show. This is after 2 days. He could read now the letters. Now what is the problem now?
അത് C A T cat.
Okay. അടുത്തത്
C H A I R CHAIR.
Reading it down.
CHAIR വാക്കെന്താ? ചെയറോ? ചെയർ.
Phonemic conversion.
CON L അല്ലേ? COLO LON E N L COLONNEL. ഒന്നുകൂടെ മൊത്തം പറഞ്ഞ COLO NEL കൊളോണൽ.
Okay.
Dyslexia.
Okay, this is typical surface dyslexia. It's not very commonly seen, so that's why I thought I'll show this video. This letter by letter reading is a phenomenon whereby the patients with acquired dyslexia decode words by sequential identification of component letters. The majority of these patients can still read by sequentially identifying each letter and read them aloud. Then what they do is they read them aloud, their letter by letter, and then listen to the letter voice, letter sound that they are spelling it out, and interpret through this intact auditory cortices and process them through the usual pathway of verbal speech. Letter misidentification, visual reading, errors are more common. Now, this is the pathway, the reading pathway. One should be aware that two ways one can read. One is the lexical reading, the other is a phonological reading. From the visual cortex, impulse goes to the visual association cortex and go to the visual word form area where you can read as a whole word. That is the usual way of what we read is what we read, don't we read like letter by letter. We see the whole word as such and then read. Then only you can have a fast reading. That is the usual way of reading. This is called a lexical, this is the word dictionary we have, and from there we choose and then read it. The other way of reading is, but this method of reading, we cannot read non-words or some other name, etc. Suppose a name like coal and all, we can't read because that's not a common word in his dictionary. So you have to read by letter, a new word. So non-words and irregular words, you cannot use the, non-words cannot be read by this method. So this is another method you read, is a phonological way that we see, just like what we have already seen. He sound out the phonemes or letter by letter and links up the phoneme into a meaningful word. That is the phonological way. So what happens in surface dyslexia is this area is affected. That is called the visual word form area in the fusiform awareness is affected. So in the lexical pathway that quickly process familiar old words is affected, patients have difficulty recognizing familiar words. They are still able to read words using the sublexical or phonological pathway, which involves sounding out each syllable, just like what the patient was doing. C, H, A, I, R, C, H, I, like that. Reading is slow and laborious. There is no instant recognition of familiar words. The patient is able to correctly pronounce regular words that have a simple grapheme to phoneme relationship, words that are pronounced the way they are written, like water, table, they can read. But they have difficulty pronouncing words with irregular pronunciation. That is why the kernel he read it as colonel. Such as thought is a very irregular word. He will read, this patient will read thou, jht, that read. Pseudonym, the P is silent, they will read it as pseudonym. That's what they read it. So that is the way, that means irregular word, they find it difficult through the, if you read through the phonological way. So this is the this is the visual word form area is affected. The fusiform awareness surface dyslexia. If you get the phonological pathway is affected, you get phonological alexia. That pathway is the pericipian area. If both are affected, you get the deep alexia. So this is the pathway by which we are able to read. From both cortices, it goes to the contralateral, to the left hemisphere, the dominant hemisphere language area. The usual site is this area where there is a left cortical infarct lesion cutting off the visual fibers. So you get the right homonymous made up here. The only pathway by which the patient can read is impulses coming from the contralateral occipital lobe, which has to cross through the splenium to reach the contralateral or left language area. So if this infarct happens to cut off this fiber coming from the contralateral occipital lobe, then this situation arises. The patient will have an alexia without agraphia. The same thing can also occur with a lesion here in the subangular area if it cuts off fibers from both occipital cortex to the alangular area. The lesion is happening here only in this area, cutting off only from one half, then what we call a hemilexia. That means they will be only able to read the contralateral, this thing they will not be able to read, only ipsilateral they will be able to read. Okay. Now let us see the same patient. Let us see what does this patient show. He is shown a key.
Pen.
പെന്നാണോ?
He said it's a pen.
തൊടാൻ പറ്റില്ല, പിടിക്കാൻ നോക്കിയപ്പോ പിന്നെ തൊട്ട് താക്കോലാണോ? ശരി, ഇനി കയ്യിലെടുത്ത് വെച്ചാൽ.
No, so what do you think he said?
Visual agnosia.
Yeah, it could be visual agnosia. Anything else? It can be many things.
Optic aphasia.
Yeah, that's optic aphasia is visual naming, correct? Yes. It's got a naming problem, visual anomia, or it could be visual agnosia, or it could be semantic loss. Even say semantic memory loss of that object. That also can, but is equal to identity, you're not able to say what it is. So let us see, sort out the issue one by one. Visual agnosia can be either apperceptive or associative, or it's a modality specific anomia called visual anomia. And is it a semantic categorization deficit? Semantic categorization deficit means that there is a amnesia for the particular category of the object, memory loss for the particular category, so that the visual thing that will be lost. So what can this can cause this kind of inability to recognize or name an object? Now, first one, let us see how to rule out an apperceptive agnosia. What test will you do in this patient?
You can ask him to describe the shape, or ask him to draw or copy looking at it.
Ask him to match. Okay.
Match. Okay.
Copy, that's the thing which you can do. So this patient is asked to match.
ഇത് ഒരുപോലത്തെ സാധനങ്ങൾ ഒരുമിച്ച് വെക്കണം. ഒരുപോലത്തെ സാധനങ്ങൾ ഒരുമിച്ച് വെക്കണം. പല പല സാധനങ്ങളായിട്ട് ഇരിക്കുന്നത്. ആ കാണുന്നതല്ല, ഒരുപോലത്തെ സാധനങ്ങൾ ഒരുമിച്ച് വെക്കണം. എടുക്കാം.
Okay, so he's able to match.
Not apperceptive.
Yeah, that means it is not apperceptive agnosia. So what remains is now, is it now associative agnosia or not? What will you know? Do you know it is not a semantic loss, but only associative agnosia?
And ask him to describe what it is used for.
So, but that visual agnosia also, they will not, both they will not be able to tell.
Copy.
They will be able to copy. Just like the other patient, we have already seen, they were able to match me. They were able to copy also, without understanding what it is.
Sir,
What do you want to differentiate between?
Between visual agnosia or a semantic loss.
Other modalities with which he can identify the.
I can ask him what you used to write. What's the thing which you used to do?
Yeah, that is one another kind. I'll come to that portion later on. To differentiate, is it a visual agnosia, not an agnosia of other modality also? You have to check whether he is able to recognize the object through other modality. I will show you. The visual agnosia means he will be able to identify the object by other sensory modality. Now, see the same video I'm showing again.
Pen ആണോ? ശരി, അത് എടുത്ത് നോക്കിക്കേ. പെനയാണോ? അറ്റൊക്കെ പിടിച്ച് നോക്കിക്കേ.
എഴുതാൻ പറ്റുന്നതല്ല.
It's not visual agnosia.
അത് മാറ്റി വെച്ചു. അത് താക്കോല താക്കോലല്ലേ? ഇനി ഇതെന്താന്ന് നോക്കിക്കേ. തൊടാൻ പറ്റില്ല, പിടിക്കാൻ നോക്കിയപ്പോ പിന്നെ തൊട്ട് അല്ല, അപ്പൊ ചെന്ന് പിടിച്ച് നോക്കിക്കേ. ആണോ? ഇതോ ഇതോ ആണോ? ശരി, ഇനി കയ്യിലെടുത്ത് വെച്ചാ
It's telling still it is a pen, that's what it's telling. So this again another video of the same patient.
അതെന്താ സാധനം? ഇതെന്താ സാധനം?
ഇതോ
എന്തിനു വേണ്ടി ഉപയോഗിക്കുന്ന?
So what does it mean? is able to be in visual agnosia should be able to identify sensory modality. The fact that he could not identify or tell the use of the object in multiple sensory modalities, it is a semantic categorization deficit. That means this is how it's a neuropsychological model for agnosis. See, we recognize an object through various sensory modalities. Visual modality, either by seeing the picture of the key or the written word as key. The auditory modality, heard word as key or the sound of the jingling sound of the key or by touching the key. If the input from each modality does not reach the semantic store, the agnosia results. So the visual part, the perception is normal. The perception is stripped of its meaning because it is not reaching the semantic store. In visual, if this is affected, only visual agnosia occurs. If the input from the auditory modalities fail to reach the semantic store, you get the auditory agnosia. If the input from the somatosensory modality does not reach semantic store, you get tactile agnosia. In a person who has got all the three modalities affected, it is likely that it is not an agnostic problem, more likely a semantic store problem. So where he has got lost, all the things have been lost. The naming comes subsequently after he has identified the object. It goes to the language area or the lexicon to name the object. The disconnection between the two results in the naming problem or the anomia, visual anomia, depending upon what the category it is. In anomia, all will be lost. In the other variety, only visual input will be unable to name. Well, let us see this video. Now, before that, I'll come to the other question. The visual agnosia can be actually of two types: visual associative agnosia and visual semantic agnosia. Semantic means the brain does not have the memory of that object in its brain. So, for example, if it is a pen, the pen is not in his brain at all. So that also will not be able to identify. Or, as shown in this picture, the input here is lost. Again, he will not be able to recognize the object. Putting it in other words, this is a visual associative agnosia. Here is a visual semantic agnosia, where one part of the semantic story is lost, where he has got other modality may be preserved. How to differentiate that two? That the differentiation is that by looking at asking for the visual imagery. Visual imagery is asking him to remember the things. The person with visual associative agnosia, only the perception is stripped of his meaning. What he sees, he cannot recognize, but that is in his brain. So he can imagine things. He can imagine a pen. He can tell the use of the pen from his mind. But only visual modality will not be. But in the case of a semantic visual agnosia, which by definition is not a true agnosia, the patient does not have the store of that imagine in his brain. And that's what that answers to Dr. Joy's question. Let us see what does this video show.
ആ കണ്ണാടിക്ക് ഒരു പെക്യുലാരിറ്റി ഇല്ലേ? കണ്ണാടി അല്ല വട്ടം റൗണ്ടുള്ള കണ്ണാടി അല്ലേ?
കണ്ണാടി റൗണ്ടുള്ള കണ്ണാടി
അല്ലേ? ശരി. ജവഹർലാൽ നെഹ്റുവിനെ കേട്ടിട്ടുണ്ടോ? ആണാണോ? ആണോ പെണ്ണോ? പെണ്ണാണ്. നമ്മളാണ് സംശയമാണല്ലോ. മോളുടെ പേരെന്നാ?
ആശ.
He could remember his daughter's name, everything, but the person who is sitting in front, she could not identify who she is. So, patient could not recognize by vision. So, what is it? Prosopagnosia? Am I audible?
Yes,
Whether he can understand
Yes, sir.
when the person speaks.
Pardon?
If it is prosopagnosia, when the person speaks, he would be able to identify the person.
Exactly. He will be able to identify. Patient is able to identify. Correct. In this patient, they are able to identify the doctor. The moment doctor starts speaking, he says, "This is doctor." So it's prosopagnosia. But one more truth.
Can this be called visual agnosia itself, sir? Because he has got difficulty identifying other things.
Yeah.
So can we say it's prosopagnosia, or could be a part of that generalized visual agnosia?
Yeah. It could be part of general agnosia, but usually what happens is that person who has got, you could not recognize any other object, still they may be able to recognize the face, and vice versa also. So putting in other words, a person can have isolated prosopagnosia with the normal recognition of the object, or a patient can have total an object agnosia with preserved prosopagnosia. So these can be occurred together or can be independently occurring, because the two the representation and analysis, the two different areas are involved. So it can be selectively affected, need not become.
But if the patient has a visual agnosia, he can have agnosia for face also. That could be a part of the visual agnosia itself only, no?
Yeah, what you said is correct, but this is separate function as it is. I'll come to that point. The answer will come just after 2-3 slides. So what else is possible in this patient? A patient is not able to recognize the face. Can be due to his semantic loss also. So invariably what you should ask is that if you see a picture is not able to recognize.
Mahatma Gandhi,
I'm asking who is Mahatma Gandhi?
Mahatma Gandhi ആരെന്നറിയോ അച്ഛന്? മഹാത്മാ ഗാന്ധി ആരെന്നറിയോ? ആരാ? നമ്മുടെ നമ്മുടെ സ്വാതന്ത്ര്യ ദിനം എന്താണെന്നറിയാവോ? സ്വാതന്ത്ര്യ ദിനം എന്താണെന്നറിയാവോ?
That means that even though he could not recognize the person by face, all the semantic aspect of that person in is there in his mind. He knows Mahatma Gandhi, who is Mahatma Gandhi, is even the date of independence he remembers, but he could not recognize only by the face. And that only you can call it prosopagnosia. If that is also lost, it becomes a semantic loss. Okay. Now, regarding Joy's question, object recognition and face recognition, two different streams of function. So one may not go with the other thing.
Mahatma Gandhi.
No, he could tell all about Mahatma Gandhi and the date of independence. So it's not a semantic memory loss, but a true prosopagnosia. Now this is the same thing I have shown. Now the thing is this, just like the previous visual agnosia I was talking about, the prosopagnosia can also be having associated amnestic variant. Associative means the picture does not enter in this, it does not go into his memory bank where the picture is stored. Okay, but here it is not, it's not the amnestic variant, it's associated. That is why you could tell all about Mahatma Gandhi. The amnestic variant, he could not tell about Mahatma Gandhi. You not recognized, I will not be able to tell about Mahatma Gandhi. So differentiate. Again, the visual imagery is going to help. He can imagine Mahatma Gandhi and everything in his mind, but in amnestic variant, that sector is lost. The fusiform gyrus and its adjacent inferior temporal occipital gyri have been labeled as a fusiform face area, since they are preferentially activated with static facial features. The activation is usually bilateral, although when unilateral, it has got a right hemispherical predominance. Let us see this patient. Same patient. What color it is?
There color acha?
So what is he having now? He could not identify the color. Tell the color.
Agnosia or anomia.
Or amnesia.
Okay. Or it could be color blindness also.
Yeah, color agnosia, anomia, or blindness.
Yeah, color blindness, color agnosia, color anomia, or color amnesia. Anything is possible. Correct?
Yes.
Yeah. So it's a central achromatopsia, color anomia, color agnosia, color amnesia. That is how to sort out this issue now in this patient. Now, what will the first thing you do?
Matching colors.
Not matching colors come Matching colors, correct.
Matching.
Yeah, I heard a different. Yeah, you have to match the color.
White,
എന്നാ ശരി ആ കളർ ഇത് ഇവിടെ അങ്ങനത്തെ കളർ വേറെ എവിടെയെങ്കിലും ഉണ്ടോ അതേ കളർ
ഈ കളർ പോലെ തന്നെ വേറെ എവിടെയെങ്കിലും കളർ ഉണ്ടോ
ഇതിലൊക്കെ നോക്കി
ഇങ്ങോട്ട് നോക്കേ ഇതിനകത്ത് ഏതാ കളറ് ഈ കളർ പോലെ ഇരിക്കുന്ന കളറ് ആ അതല്ലേ അതുപോലെ ഇരിക്കുന്ന അതാ കളർ അല്ലേ
ഇതുപോലെ ഇരിക്കുന്ന കളറോ
Okay, so what does it rule out now?
Achromatopsia.
Rule out achromatopsia. Now what the other things remain? Now what else will you do now? What's the next step?
You can ask him the color of something.
Yeah, exactly. You have to give a picture and ask him to color, choose the correct color for that particular object. For example, if there is an orange, you are written in a black and white, you have to choose orange color. If it is what you call some banana, you have to choose the yellow color like that. So he knows what color to be good for the particular object to find out whether color agnosia or not. So the patient can be asked to color a picture to identify the color agnosia. So a patient cannot choose the correct color for a particular object. In this patient, he could not choose the correct color from an array to color an orange, apple leaf, etc. So what does it mean? He could not choose it.
Color agnosia.
Yeah, it could be color agnosia or color amnesia also.
Then we can ask him what is the color of the sky.
Yeah, exactly. Correct, perfectly right. But not anomia. Anomia is not there. Because anomia patient will be able to color. They are unable to name, but they can color it, choose the color, everything perfectly. So it is not anomia. So it is not achromatopsia. So what remains is color agnosia and color amnesia. So let's see what I have asked this patient.
Apple.
What is the color of apple?
Blue.
Is it
blue or no apple? ആകാശത്തിന്റെ നിറവോ?
What's the color of the sky?
Green.
Is it
green ആണോ?
Sky blue. ആകാശം നീല.
നീലാകാശം ഓർത്തോണ്ട് അച്ഛൻ പറയുക അല്ലെ? ശരി. നമ്മൾ ചോരയുടെ നിറം ചോപ്പ്. നമ്മള് ഇതില്ലേ നമ്മുടെ ഇലയുടെ നിറം നീല. നമ്മൾ ഇതില്ലേ പതാകയില്ലേ, നാഷണൽ ഫ്ലാഗ്.
So he could not tell the color of the object from memory. So what is he having now?
Amnesia, color amnesia.
The color amnesia. Again pointing to a temporal lobe, inferior temporal lobe lesion, where these stored memories of the objects are lost in this patient. Some of them are lost. Some of them preserved, like face recognition, say face memory is preserved. The other thing, some of them are lost. So this is another, in color achromatopsia, they will see red and green like this as shades of gray. They cannot say red and green, cannot color pictures, cannot match colors, but can match color. In case of color agnosia, they can match the colors, but cannot say red and green, cannot color the picture, but able to retrieve the color and object from memory in color agnosia. In color anomia, they cannot name the color, but they can color the picture normally. In color amnesia, they can say red or green, cannot color the picture, but unable to retrieve the color from the memory. So color amnesia is a more profound disorder, inability to retrieve from semantic memory the typical color of an object. Fail to answer questions concerning colors of object, like what color is a lemon, or banana and sunflower the same color, etc. And they fail to color an object because they got amnestic problem in that, and fail to judge whether a drawing is colored correctly or not. So this is regarding the case. This patient had a large irascible bleed spanning from the left occipital to the left temporal area, to the inferior back. So it's mainly in inferior, the ventral stream is affected in this patient. Okay, any questions in this case?
So do you have image of that patient's CT?
In fact, I searched for that. I couldn't locate it somewhere in my laptop.
Okay.
So, because I bought the case not for, the etiology. Etiology is, of course, it's hemorrhage or stroke, whatever it is. But to sort out what is the symptomatology it is. That's the idea of bringing the case. How to go about whether to find out whether it's a color blindness or amnesia. How to go about is it true visual agnosia or is it semantic memory loss? And what are the steps to be done like this? That's the idea of bringing this case.
Your book has been very helpful, sir. You and Anand sir's book.
Yeah, the pictures are second. It has gone for second edition printing.
Are there any changes in the
first edition? Yeah, a lot of changes have made.
How many books did you sell in the first edition?
It has gone out of print. I
think it was not properly promoted. I think
not promoted at all. They did not promote. Many people are asking if it's not available. Anyway, second edition. Okay, any other questions?
Sir, one doubt, sir.
Please.
How will you test it if there's a right hemichromatopsia, like
hemiachromatopsia?
Yes, sir.
In fact, the fusiform gyrus is close to the inferior bank of the calcarean cortex. If one fusiform gyrus is only one side is affected, you can have a contralateral color vision loss. The same side will be preserved because the contralateral and fusiform gyrus is picking up is analyzing the color. So one fusiform gyrus on one side will result in contralateral hemiachromatopsia. If the lesion extends a little more backward, it is going to cut off here in the inferior part of the calcarean cortex as well. If that also occurs, what will happen? The left of the visual field will be normal color, everything normal. The right of the visual field, upper part will be blank or black, and the lower part will be seen but devoid of color. Okay, that's the thing they get.
Okay, sir.
Hemiachromatopsia to unilateral fusiform gyrus lesion.
Okay, sir.
Any other question? Okay, then shall I go to the next one?
Yes, sir.
Okay. This is a story of a 74-year-old diabetic old man. Is to walking difficulty in the form of inversion of the left foot while walking for the last 3 years. No numbness, no root pain. For the last 2 years, he noticed imbalance while standing, as well as he said tendency to fall forward while bending. Whenever try to bend to take something, he tend to fall forward. This is the complaint of the patient. Go to the examination. I was concentrating in the lower bone was normal.
Very good.
Evasion is normal on the right side. Grossly we very weak. Checking the inversion. Normal on the right side. Weak on the left. It's really good for right side. That's weak on the left side. Another question is weak on the left side. Completely normal. Protection is normal.
അങ്ങനെ പിടിച്ചോ
Direction.
ഇനി അടുപ്പിച്ച് വെച്ചോ ചേർത്ത് വെക്കും ഇനി കീഴോട്ട് തള്ള് കയ്യിലോട്ട് തള്ള് ഇതും തള്ള് മതി ഇനി ഞാൻ പറഞ്ഞു വിട്ട്
With the reflexes, reflex are played under the books like this. Both analytics for love.
ചുമ്മാ അടിച്ചാ എല്ലാം കൊടുക്കാതെ
Bandar is outgoing on the right side.
കാര്യം വലിക്കല്ലേ
Left is
ഒരു മിനിറ്റ് മുറുക്കി പിടിച്ച്
When we seeing the pain, Bandar started examining the upper.
മുറുക്കി പിടിക്ക്
Power was normal, tone was
ബല്ലിങ്ങനെ അകത്തി പിടിച്ച് ഇതും അകത്തി പിടിച്ച്
almost like that.
ശരി ഇങ്ങനെ കാണിച്ച സ്പീഡിൽ ശരി കൈ താത്ത് വെച്ച് ലൂസാക്കി ഇട്ടോ ബലം കൊടുക്കാതെ ഇങ്ങനെ വെച്ചോ
This is the one. Internal pressure in there.
വേദനയും ഇതും ഒരേപോലെയാണോ
Sensation. Pain is normal, equally both sides.
ഇതും ഒരേപോലെയാണോ അങ്ങനെ
That's again normal.
ഇല്ല
Vibration decrease.
ഇപ്പോഴേ
Low knee.
ഇല്ല ഇപ്പോഴേ ഇപ്പോഴും ഇല്ല
They're not able to feel.
ഇല്ലെങ്കിൽ ഇല്ല
And is able to feel normally.
ഓക്കെ കിട്ടോ ഉണ്ട്
Also the ear crust.
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴേ
The upper limb.
ഇപ്പോഴേ കറക്റ്റ് അതേ ഇപ്പോഴേ 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 പറഞ്ഞുവിടാം
Good and both too.
അതറിഞ്ഞത് ഇപ്പോഴേ പറഞ്ഞു ഇപ്പോൾ താഴെ മുകളിലോ ഇപ്പോഴേ ഇപ്പോഴേ
It's a wrong thing. The other was negative. Okay. This is the rhombus.
ഇനി കണ്ണടച്ച് വെച്ചാ ഒന്നുകൂടെ കണ്ണടക്കി കണ്ണോണ്ട് പിന്നെ പിടിച്ചോളാം ചേർത്ത് വെച്ച് ഇനി കണ്ണടച്ചോ മതി ഇനി അച്ഛൻ ചുമ്മാ നടന്നു പോവാ മതി കണ്ണ് തുറന്ന് നടന്നോ നടന്നോ സ്പീഡിൽ നടക്കച്ചാ ഇനി തിരിച്ചു നടക്കണം തിരിഞ്ഞു നടക്കേ നടന്നോ തിരിച്ചു വന്നേ വെച്ചാ തിരിച്ചു വന്നേ ഒന്നുകൂടെ സ്പീഡിൽ വാ അച്ഛാ സ്പീഡിൽ വാ ഒന്നുകൂടെ നടന്നേ ശരി അച്ഛൻ തിരിഞ്ഞു നിന്നോ
He cannot stand. Elevate his leg. He cannot stand. He cannot stand on his toes on both sides. So, an examination, tone normal in the lower limbs, weakness of left dorsiflexus, evertus, EHL, flexor, hallucis longus, and both plantar flexors. He cannot stand on toes. Other muscles appear normal. Upper limbs examined later, tone power normal in the upper limbs. DTR normal in the upper limb. Lower limb knee jerks well insensible may be brisk. Angle jerk absent bilaterally. Abdomen normal in all four quadrants. Pandas right upgoing, left indefinite. Sensation upper limbs normal. Lower limb touch pain normal, impaired JPS over both toes, vibration impaired up to knee, normally felt in the iliac crest. Rombox positive, tandem walking defective, SLR negative. If you want to see the findings again, just ask me, I'll show 1 second.
So L5 S1 radiculopathy on one side and S1 radiculopathy on the other side with some myelopathic features somewhere above.
Right. That's your myelopathy plus radiculopathy, right?
Yes, sir.
More of peripheral neuropathy, sir, because JPS and vibration involved with absent reflexes in the low limbs. Some pyramidal component is also there in the form of extensor plantars.
Yeah. The question now is whether it's a multiple nerves affected or multiple roots affected. That's the first. Let's get pyramidal signs are there. Let us sort out the element paralysis first.
Multiple roots.
Multiple roots. Why not multiple nerve?
If it is a multiple nerve, only we have the left dorsiflexor and the left everters are weak. While in the right side, there is a definite asymmetry. Right side, the dorsiflexor and the everters are not weak.
I could take it. It could be tibial nerve involvement in the right side.
But usually nerves are more affected with more preferences to the superficial peroneal rather than the tibial.
Yeah, that's correct.
More commonly affected than the tibial.
Right side inversion was normal, no?
Left side inversion was normal.
No, right side also inversion was normal. If the tibial was involved.
Normal.
The tibial was involved, inversion also, inversion also should have been affected.
Even when lying down, when I asked him to push against my hand, he did it very he did almost really good power was there. Only made him to stand on toes that became obvious. So that means the weakness is not gross. So that means that subtle difference, you can't make it out. The inversion, you can't see inversion is normal just by examining on the bedside. I don't know whether you got the point. Yeah. See, when plantar flexion also, it's got a gait 5 power on the right side, touching at the bedside. But he cannot stand on toes. Such a manual we couldn't do for inverters. We can't ask him to stand with inverted position and things like that.
This kind of asymmetry can occur in root rather than the nerve because
that can occur in nerves also. Mononeuritis multiplex, no? The name itself is mononeuritis multiplex.
But the tibial nerve won't explain the sensory findings.
Yeah, you're right. That's mononeuritis multiplex can. Multiple nerves are affected, some other is affected, some motor is more affected.
The right tibial is involved, you can't explain the sensory findings on the right lower limb because it's there on the dorsum of the foot also.
No, the point is that they can have subclinical involvement also. In mononeuritis multiplex, whether see, they can have symmetrical sensory loss, plus multiple nerves may be affected patchily. Mononeuritis multiplex can take any pattern.
So can the plantar become extended?
No. Plantar, we can leave out the plantar for the time being. That is against for both.
Sir, can you show the findings slides once again?
Yeah, the way he walks.
With findings.
No, you want to see the findings once again?
Yes, sir. This slide.
Okay. Give me the video.
Did he have sensory symptoms in the right lower limb?
No sensory symptom.
If that been involvement of the sensory, you should have at least complained of if you say it's a subclinical involvement, before you find signs, there should be symptoms, no?
The absolute point, it's because even radiculopathy also we expect some sensory symptom when the patient's got sensory loss.
Did you check the hip abduction in side? With the patient made to lie down the side?
Correct. So that's a point which we had thought was hip abduction was normal. That was speaking against the radiculopathy. Correct? Such a severe dorsiflexion weakness and plantar flexion weakness. Sparing at hip abduction is normal. Correct? That's a point favoring any other. Okay, we'll come to that. Now this is examination. The lower limb, no, lower limb. Actually, 1 second.
അതല്ല കറക്റ്റ് അത് കറക്റ്റാ അതേമാതിരി ഇത് പൊക്കാൻ നോക്കി പിടിച്ചോ അങ്ങനെ പിടിച്ചോ ആ കറക്റ്റ്. ഇനി വെച്ചാൽ ഇങ്ങനെ ഇരിക്കണം. അങ്ങോട്ടാക്കാൻ സമ്മതിക്കല്ലേ. അത് തന്നെ കറക്റ്റ് കറക്റ്റ്. ഇങ്ങനെ പിടിച്ചോ. മതി, വെരി ഗുഡ്. അടിക്കണം. അതേമാതിരി ഇത് ഇങ്ങനെ ഇരിക്കണം. പറ്റണില്ല. ഇങ്ങോട്ടാക്കാൻ പറ്റും നോക്കിക്കേ. ഇങ്ങനെ പിടിച്ച് നിർത്തിക്കേ. ഇല്ല. ഇങ്ങനെ ഇരിക്കണേ. അതേപോലെ ഇതിനകത്തോട്ട് പിടിക്കേ. പിടിച്ചോ. അത് പറ്റും. നിങ്ങളുടെ വീട്ടിൽ മുകളിലോട്ട് പിടി. അതേ പിടിച്ചോ. അതേപോലെ പിടിച്ച്. പറ്റണില്ല. കീഴോട്ട് മടക്കിക്കേ. മടക്ക് മടക്ക്. ഇത് മടക്കിക്കേ. കീഴോട്ട്. പറ്റണില്ല. പിടിച്ചേ. ഇതിറുക്കി പിടിച്ചേ. ഇതിറുക്കി പിടിച്ചേ. പറ്റണില്ല. ചവിട്ടിൻ്റെ കയ്യിൽ ചവിട്ട്. ഇത് ചവിട്ട്. ചവിട്ട്. ആഞ്ഞ് ചവിട്ട് കേട്ടോ. അങ്ങനെ പിടിച്ചോ. കറക്റ്റ്. ഇനി അടുപ്പിച്ച് വെച്ചോ. ചേർത്ത് വെച്ചോ.
Okay. You want to see the gait once again?
ഇനി കണ്ണടച്ച് ചേർത്ത് വെച്ച് ഇനി കണ്ണടച്ചോ. ഇനി അച്ഛൻ ചുമ്മാ നടന്നു പോവാ. മതി. കണ്ണ് തുറന്ന് നടന്നു പോവാ. നടന്നോ. നടന്നോ. സ്പീഡിൽ നടക്കച്ചാ. ഇനി തിരിച്ചു നടക്കണം. തിരിഞ്ഞു നടന്നേ. തിരിഞ്ഞു നടക്ക്. നടന്നോ. തിരിച്ചു വാ. തിരിച്ചു വന്നേ വെച്ചാ. തിരിച്ചു വാ. തിരിച്ചു വന്നേ. ഒന്നുകൂടെ സ്പീഡിൽ വാ. അച്ഛാ സ്പീഡിൽ വാ. ഒന്നുകൂടെ നടന്നേ.
Some amount of battling.
ശരി. അച്ഛൻ തിരിഞ്ഞു നിന്നു.
Okay. So, what do you want to do now? Let us see. This is the question I was asking now. Is the lower limb weakened due to multiple nerve neuron roots?
So there is some clawing also on the toes, no? On the right side, sorry, left side.
Not very convincingly there. I didn't think so.
Okay, sir.
Sir, left hip extensor weakness is there, no, sir?
Pardon?
Left hip extensor.
But normal. On bedside patient, normal.
Okay, sir.
Let us see what is against multiple nerve affection. The point what all Joy said is correct. But I want the point by which you said like this. If you do very carefully, tibialis anterior is normal power. You can see that tibialis anterior jutting out. I could, in the dorsiflexed position, I was checking the inversion. That is done by the tibialis anterior. So that is against a conperoneal palsy. See, if you think of a conperoneal palsy, you have to account for the everter weakness and EHL weakness. You expect tibialis anterior to be normal. It will be affected. But here it is paired but the root supply two are different. The dominant supply of tibialis anterior is L4, inversion then L4. On the other hand, the other muscles are L5. So if it is an L5 radiculopathy as well, L5 S1 radiculopathy, you can explain this finding. But with multiple nerves, you cannot explain the tibialis sparing of the tibialis anterior because that is supplied by the conperoneal nerve. Let us see the same video. In fact, there were one right.
അത് കറക്റ്റാ.
See the tibialis anterior tendon.
പിടിച്ചോ. അങ്ങനെ
This is
പിടിച്ചോ.
the muscle shining.
ഇങ്ങനെ ഇരിക്കണം. അങ്ങോട്ടാക്കാൻ സമ്മതിക്കല്ലേ.
Is that
അത് തന്നെ കറക്റ്റ്.
the normal part?
ഇങ്ങനെ പിടിച്ചോ. അത് കറക്റ്റാ.
You understand? So that's the point by which you suspect that it is not in the multiple nerve, the multiple roots are affected. So weakness is not in the distribution of CPN. T is paired, means it is radiculopathy because the root value of is L4. So as Joy said, examine the hip abduction once again in the lateral position.
കീഴോട്ടാക്കാൻ സമ്മതിക്കില്ലേ. മതി. ഇനി കൊടുത്തി മതി. ഇനി പൊക്കി പിടിച്ചോണം. കീഴോട്ടാക്കാൻ സമ്മതിക്കില്ലേ. പൊക്കി പിടി.
In fact, hip abduction. So the lesson is that you have to check always the lower muscles in the offending position. that is against gravity, just like ask the patient to stand on toes, and if many a time we don't do that. To save time, we only do it in the lying down position, check the hip abduction. Make it a point to check in the offending positions. Otherwise, you will miss the weakness. Okay. Now let us look at the gait once again.
Yes, sir, that's rattling, sir.
Is it waddling? What is happening to the knee joint? Knee goes into hyperextension by
He is hyperextending.
on both sides, more on the left side, not as wrongly written, more on the left side. See the video once again. The knee goes into hyperextension. The knee is going hyperextension both sides, more on the left. It's going backwards. See that? So what does it mean?
Hamstring weakness.
Okay, it can be due to the hamstring weakness will not cause this thing. Knee with hyperextension. But there is
the approximate this thing abductor this thing is weak, sir. So
quadriceps weakness.
Yeah, it can occur due to two things. Either due to quadriceps weakness they can buckle, or due to the weakness of the gastrocnemius they can. Gastrocnemius, not soleus. If the soleus is weak, actually, or the plantar flexors are weak, both might weak, the knee goes into flexion while walking. On the other hand, if soleus is preserved and gastroc is weak, the knee goes into hyperextension. So also quadriceps is weak, the knee goes into hyperextension. But when you get that, the commonest cause is not that. Commonest cause is the knee joint problem, the injury to the anterior cruciate ligament. Well, let us see. This is the how this goes into.
What about hamstring weakness? Wouldn't it produce hyperextension? What does it produce?
Hamstring weakness will not produce hyperextension.
What will it produce? Nothing.
I don't think anything will. Posture change, I don't think it will produce anything. Now, why should quadriceps weakness produce hyperextension? Is because the weakness of quadriceps results in weakness in knee extension, as you know. Here, the active contraction of the soleus may help to pull the leg backward, passively extending the knee. This is the quadriceps compensation.
But soleus doesn't cross the knee, no?
It does not cross the knee. That is why, even in the case of soleus weakness, you will not get knee will not go into hyperextension.
No, you said in quadriceps weakness, soleus action produces hyperextension of knee, no?
Yeah, and no, not that way. See, in this case, what happened in the case of quadriceps weakness, patient stance is weak. So it has to be kept steady by the strong contraction of the soleus to make it steady. I'll explain it a little more later. Read the subsequent sentence here. That is called quadriceps compensation. With quadriceps weakness, the individual may lean forward over the quadriceps at the early part of the stance phase as the weight is being shifted to the stance leg. Normally, the line of force falls behind the knee, requiring quadriceps action to keep the knee from buckling. That is why the quadriceps acting. By leaning forward at the hip, the center of gravity shifted forward. The line of force now fall in front of the knee. This will force the knee to go backward in extension. It's actually not due to the weakness per se, but it's not the weakness. It is a compensatory phenomena which could prevent the fall due to the shift of the center of gravity. That is the quadriceps weakness producing this thing. In gastroc weakness, what happens is that as it originates above the knee joint, and it's not only a plantar flexion, that's also a flex of the knee, as you all know. Unlike soleus, which is a function is only plantar flexion angle. So it helps stabilize the knee on standing and prevents hyperextension. Hence, gastroc weakness results in weakness of the knee flexion as well as weakness of the plantar flexion. Hence, an isolated gastrocnemius weakness without weakness of soleus, the knee hyperextends while standing. That's explanation. If you understood or not, I'll tell once again. So what happens is that when the plantar plexus are weak, when you stand, the angle goes into dorsiflexion. Okay, it will be shifted forward. With shifted forward, central gravity is also shifted forward. So what will happen? The soleus will contract strongly to keep it ready, steady, so that it will not fall forward, tilted forward. So in the case of gastric weakness, in the case of soleus weakness, what will happen? That fall forward, the only muscle acting is the gastric weakness, gastrocnemius muscle, which in addition to keeping it steady in the angle, flexes the knee. So the patient walks with a flexed knee if the soleus is weak. On the other hand, if gastroc is weak, the soleus will keep it steady in the angle will be kept steady because it's a strong muscle. But the knee goes into hyperextension because the compensation provided by the gastroc is lost. Because gastroc is keeping the knee flexed, that is also goes into hyperextension. That is the mechanism of hyperextension soleus weakness. Sorry, gastrocnemius weakness. Anyway, even if you let's not remember this point. When you should think is then plantar plexus weakness, they walk with a flexed knee. We find that it's a plantar plexus weak, but can also knee hyperextension usually occurs with quadriceps weakness, but also can occur with gastric weakness.
Sir, hello, sir.
Yeah, please.
Sir, what situation we will think of in which there is a dissociated weakness between the gastroc and the soleus? Sir, what should we be? What situation we should be thinking of?
What you said is perfectly right. Now, this sometimes in a radiculopathy or a neuropathy, all muscles may not necessarily be affected uniformly. See, for example, in this particular patient, is predominantly an affection of the gastrocnemius. Because there's no quadriceps weakness in this patient.
Oh, okay, sir.
Dr. Madhu?
Yeah.
See, quadriceps is normally causes extension of the knee, no?
Correct.
So if it is weak, then it should cause flexion at the knee rather than hyperextension.
You're perfectly right. This is the question I had tormented my many years. Why they should, what is saying a hyperextension of the knee? But this is the explanation they have given. That's the one which I told this one. This explanation. Because it's not because of the weakness per se, because of the tilt of that central gravity forward, that keeps it awkward in this particular position.
Okay. So now if we have got a extension, if we have got a weakness of the, let us say the hamstrings, then what will happen? Suppose if there's a weakness of hamstrings, then what will happen?
And as far as I know, the hamstring weakness on standing did not produce any change in the shifter position, not be there.
Okay. So that will not. I was just thinking, on a mathematical model that if there's a hamstring, I was thinking whenever I would see any hyperextended knee, I would say it is a hamstring weakness. But then I think that is not correct. It is the quadriceps, which is little counterintuitive.
Yeah, exactly.
Yeah. Thank you, sir.
Sir, one doubt, sir.
Window.
Sir, is it the body tries to lock the knees and in the quadriceps weakness?
Not lock the knee, because you have to, when you make the central gravity in line or behind, then you have to make the shift to the body will tilt forward. That produces compensatory hyperextension of the knee.
Okay, sir.
So Madhu, these cases of genu recurvatum, which we see, you think they are because of the quadriceps weakness?
Yeah, usually this is due to the lesions of the knee joint. Usually this kind of hyperextension is due to the knee joint problem, like break of the cruciate ligament and some other damage to the joint is some commonest cause. But neurologically, these are the things we have to keep in mind.
So then we can suggest them quadriceps strengthening exercises rather than hamstring.
Yeah, correct.
Thank you.
So this investigation shows, as you all suspected, he's got a multiple disc prolapse, CBA canal stenosis, L5S1, multiple level, in fact, he's got. And now what is causing sublime plantar? we have sorted out the element weakness, what is causing the impact. We don't know. We only say it's got a pyramidal lesion by L1, where we do not know. So in a person with a lumbar spondylosis with disc disease, actually we have to investigate for a cervical associated cervical spondylotic lesion also. So what do you want?
Cervical.
This is the severe canal stenosis side for L5. L5 S1 segment is normal. Okay, the cervical spine showed a disc lesion here, but not much of a compression, but still you can make out the cord is compressed a little bit on that side, on the right side, in this cut. Anyway, that's the only thing but causing it. But whatever is a pyramidal lesion is very subtle, does not require any management on that ground. Because there's no definite pyramidal weakness in either in the upper or. So this is an unrelated finding. So I brought the case only for a discussion on how to differentiate between multiple nerve and diplopia based on this, the sparing of the tibialis anterior in L4 in L5 for diplopia. Secondly, the point that you have to examine the patient always in the offending position, otherwise we'll may miss the weakness of the hip abductors.
Sir, one doubt, sir. This plantar upgoing here, is it not the unequal distribution of the weakness of the plantar plexus versus the dorsiflexus of the toes?
Yeah,
toe.
that differential weakness can cause upgoing plantar. But remember that to produce a pseudo plantar, upgoing plantar, the weakness should be in the short muscles of the foot, not flexor hallucis longus. Here both are normal on the right side, that's a different issue. But even if you want to say there is a preferential weakness of the short muscles or the foot, you can have a pseudo plantar. Because the normal plantar response is because of the contraction of the flexor hallucis brevis and not the flexor hallucis longus. Okay, and the extension is because of the extensor hallucis longus.
Yes. Thanks.
Any other question?
So the impaired JPS and vibration in this case because of peripheral nerve, or there could be roots also?
In this case, might be due to the roots itself. Because it's a diabetic, maybe whether we can say due to that also, I cannot totally say no. Okay, any questions? Shall I go to the next one?
Yeah, Madhu. Next
Yeah.
one.
One more case.
Sir, one doubt.
Please, please.
Sir, she is tending to fall backwards. Let me see the gait. But he told that he is he's tending to fall forwards. Like when we saw the gait, he thought that he's tending to.
I'll tell you what is it. When he is bending, he's falling forward. That's history. When you bend something to take, you fall forward.
Okay, sir.
Back or backward, because its angles are destabilized. It's also got proximal muscle weakness also. Even though examination wise we are not getting hip extension weakness, hip abduction is also weak, there may be weakness hip extension also likely to be in this patient. When you make him stand only, they'll become obvious. But moreover, the angles are also unstable.
Yes. Okay.
This is another interesting case. It's a story of a 14-year-old boy presented with this clumsiness the left hand for the last 3 days. And he feels some awkwardness in left foot while walking. No headache, no sensory complaint. This is the video of the patient.
Try பண்ண அப்படி ஆயிட்டு எவ்வளவு நாள் ஆச்சு இது இப்படி ஆக்க வேண்டாடா நான் இப்படியே பிடிச்சிருக்கேன் அப்படி இப்படி ட்ரை பண்ணேன் அப்படி ஆயிட்டு எவ்வளவு நாள் ஆச்சு
deformity of the fingers.
அது நமக்கு காலுக்கு கஷ்டம் இருக்கா காலுக்கு என்ன கஷ்டம் நடக்க கஷ்டம் இருக்கு அதை எத்தனை நாள் இருக்கும் நேர பார்த்து
Painless normal, people normal.
இந்த பக்கம் பாரு ரைட்லேயே பார்த்துக்கோ என்ன இங்கே பாரு மோளில் கீழே வேணா அங்கே தெரியுதா கண்ணில் தெரியாது ஏதா பக்கம் தெரியுதா தெரியுதுங்களா ஈ சொல்லு ஈ ஈ ஈ கண்ணு மூடு நல்லா மூடு ஜோரா மூடு ஈ காட்டு நாக்கு நீட்டு சரி போடணும் சும்மா போட்டுக்கணும் ஒன்றும் செய்யக்கூடாது நான் சொல்லுவேன் முக்கியப்படி எது முக்கியப்படி விடு பிடிச்சிட்டே இருடா இப்படி பிடிச்சிட்டே இரு அப்படித்தான் புரியுதா விட இது பக்கம் பாரு அதே மாதிரி தனத்தானே இப்படி பிடிச்சிருக்கு எப்படி நிறுத்த பார்ப்போம் முடியல இப்படி நிறுத்த முடியல ஒன்று முடிச்சு இந்த வளவில் இதுக்கு சேர்ந்தா வந்துதா இப்படி இந்த வேலை தலைவரில் பார்க்க இப்படி பிடிச்சிட்டு ட்ரை பண்ண ஒன்னொன்று ட்ரை பண்ணு இப்படி பிடிச்சிக்கோ ட்ரை பண்ணு இந்த தள்ளுவழி இந்த வருஷத்தை இப்படி இப்படி பிடிச்சிட்டே இரு அணைக்காத பிடிச்சிட்டே இரு ஓகே சரி நீ இந்த கை பாட்டில் மடக்கிட்டு மடக்கி பிடிச்சிக்கோ அதே மாதிரி இதை மடக்கி பிடி அப்படித்தான் அதே மாதிரி இந்த உள்ள
कड़िमे पेट्रोल डलवाना थे तो
உள்ள கொண்டு
तो 2,500 का होगा कम से कम
புரியுதா
109 रुपीस
இப்படி பொக்கி பிடிக்க பாரு பிடிச்சுக்கோ
तो मेरे पास सब खरीदारी इसी से की जाए
मैंने बैंक से 2,500
हाँ वो कभी कोई निकालने चाहिए
ट्राई பண்ணு மடக்கி கொண்டு நூறு முடியல
क्योंकि ट्रांजैक्शंस आर इंपॉर्टेंट
அதே மாதிரி இந்த கை அகத்தி பிடிச்சுக்கோ அடுப்பிக்க சமைக்காத குட் அடுப்பிக்க சமைக்காத இப்படி மனே ரெண்டு கை அப்படி பிடிச்சுக்கோ சரி விட்டுக்கோ
common sign is negative
விரல் மட்டும் பிடிச்சு இந்த கை கைவிடு எது பிடிச்சுக்கோ இது பிடி விரல் கொடுக்க கூடாது என்ன விரல் கொடுக்காதுடா விரல் கொடுக்காது சும்மா போடு விடக்கூடாது என்ன இது பிடி விடக்கூடாது முட்டு மடக்கு சவுட்டு நூறு இல்லை இந்த பார்த்தால் அப்படித்தான் சவுட்டு நூறு அப்படித்தான் இந்த பாதம் முள்ள தூக்கி பிடிச்சிக்கோ அப்படியே பிடிச்சிக்கோ இதை பொக்கி பிடிச்சிக்கோ நல்லா இதை பொக்கி பிடிச்சிக்கோ இதை பிடிச்சிக்கோ இதில் மடக்கு
normal
இதை மடக்கி பிடி போதும்
this is unfortunately was all were apps unfortunately were all apps
பலம் கொடுக்காத
biceps are thin
லெஃப்ட் மோல்ல தூக்கு
abdominals are intact
சும்மா போட்டு கழிஞ்சு முடிஞ்சு போதும் நான் சொல்லும்போது கை முறுக்கி பிடிக்கணும் என்ன முறுக்கி பிடி கை முறுக்கி பிடிச்சிக்கோ காலி லூஸாக போடு
the right side
லூஸாக போட்டு சும்மா போடு பாருக்கா சும்மா இருந்துக்கு ஒன்றும் செய்யாத சும்மா இருந்தா போதும் ஒரே மாதிரி தெரியுதா ஒரே மாதிரி தெரியுதா அந்த சத்தமா சொல்லணும் இது தெரியுதா ஒரே மாதிரி தானா சரி உன்னோட பாரு இது தெரியுதா?
Able to feel the vibration
இது
normally.
தெரியுதா கிறுகிறுப்பு? சத்தமா சொல்லுமா தெரியுதா? இது தெரியுதா? பம் பம் அதே மாதிரி இந்த வரல சொல்லணும். இப்போ எப்படி? பம் 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 இந்த வரல சொல்லணும். பம் 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 கால்ல பம் பம்
Let the gait of the patient know.
நட ஸ்பீடில் நட 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 நடந்துக்கோ நடந்துக்கோ. ஒரு காலுக்கு முன்னாடி கால் வச்சு நட. இங்க பாரு. சரி போதும். நீ உப்பு வச்சு போய்க்க நட பாப்பா. மதி இது திரும்பி இது சரி மதி விட்டுரு. நீ சும்மா நட உன்னோட ஸ்பீடில் நட பாப்பா. ஃபாஸ்ட்டாக நட. அப்படி நில்லு. அப்படி நின்றுக்க. உன்னோட நடந்து வாங்க. சரி உன்னோட நடந்து வா. அங்கேருந்து இங்கிட்டு வா. சரி சரி
Okay.
ட்ரை பண்ண ட்ரை.
So gainers normal, motor left upper limb, tone normal, power, weakness of extension to the left wrist, finger extension, severe weakness, extension policies normal. Normal for the finger flexors, FPL, small muscles of the left hand. Left hand goes into flexed posture when asked to keep his hand stretched out. Fingers show ulnar deviation with sign neck deformity. He was sure it was normal, not there before 3 days. Right upper limb normal. DT are all absent except right triceps, which is just insensible. Abdominal reflex normal, plantar flexor sensations normal. So where is your localization?
Cortical sensations?
Normal, normal.
Left radial.
Okay, left radial.
Right parietal lobe. Right parietal lobe lesion.
Right parietal lobe, left radial. Okay.
The finger extensions are normal, so most probably a cortical lesion.
Finger extensions are severely weak. Finger extensions.
Yes, sir. The weakness indicates it's a cortical lesion.
No, that can occur with radial nerve palsy also. Posterior also something in that.
Sir, the lower limbs also affected. He has got a hemi distribution. So most likely it's in the cortex or in the basal ganglia on the opposite side.
Okay. What are the abnormalities you notice in this patient? That's my question.
He has got a dystonia of the left hand. That's
Right.
a swanneck deformity. There is a decreased positive movement of left side, especially left upper limb, and there's some dragging on the left lower limb as well.
Okay, so that's your localization. Let us see. Now, you said a radial nerve palsy. What is against that possibility?
Preservation of the triceps with the finger and wrist extensor in weak.
I did not get Bindu. You tell me once again.
The finger extensors, wrist extensors, as well as the there is a ulnar deviation, no, sir. So the radial extensor, carpal radial is also lost. So in that case, radial nerve should be lesion, should be proximal, no. So
With the weight is right. It is not the wrist which goes into ulnar deviation. It is the fingers.
So that is unlikely for a radial nerve lesion.
Correct, correct. That is correct. So it is not. That's what I'm trying to say. This is why is that the fingers go into ulnar deviation in acquired with acquired ulnar deformity. That is very, very odd posture for anything, except for abnormal contraction of the muscles. Seen as in Mumar was telling, it's like seen in dystonia. Because ulnar deformity usually will not occur with any particular muscle weakness at all. You can't explain any muscle weakness. If you find a neurological problem, the commonest condition is at old age, advanced Parkinson's disease, you can see this kind of phenomenon as a dystonia or other dystonic posture. Now, My question next is, does he have involuntary movement of the left hand?
Yes,
Yes,
sir.
sir.
Any box.
Yes.
Yes, any box.
Yeah, asking him to keep still again goes into flexion movement like that. Something like a thetoid movement or a notostereotypic movement, he goes on doing like that. So that means he has got some extrapyramidal involvement. Now, has he got any abnormality in the left lower limb?
Yes, sir. Any box.
Striatal toe.
Yes, sir.
And he has postural unsteadiness also. He just tends to waver to either side.
There is turning, not there's unsteadiness, but that does not mean it's confined to the left side. What is anything abnormal in the left side? Let us see the gait once again. I will show one interesting finding.
The hyperextension of the toes.
There is toes get dipping to the floor. Look at the left toes when he stands. After this,
ശരി പോതുമേ ഈ ഉപ്പൂറ്റി വെക്കുന്നതാണ് പാപ്പ ആ മതി ഇനി തിരുമ്പി ഇനി ശരി മതി വിട്ടേ ഇനി ചുമ്മാ നല്ല ഒന്നുകൂടെ സ്പീഡിൽ നട പാപ്പ ഫാസ്റ്റ് அப்படி நில்லு அப்படி நின்னுக்க
see the toes on the left side. See that one compared to the right. This can be flexed and dipping onto the ground. I'll show you once again.
ശരി ഒന്നുകൂടെ നടക്കുക അങ്ങനെ ഇങ്ങോട്ട് വാ.
So that's about the dystonic posturing of the left foot as well. So that means it's got a hemidystonia with weakness of the left hand. So whether even the reflexor or absent, the most likely to be a pyramidal lesion in addition. Because that so super resemble like a radial nerve palsy, but because of some odd findings like this, you have to keep other possibilities as well. So what do you want now?
MRI brain.
MRI, sir.
Okay, this is the MRI. Lesion the right caudate, internal capsule, involvement here. There is the central part is due to hyperintense, but is inverting in the central part, not inverting in the peripheral part. This is a T1 by T image, some hyperintensity outside. There is this is a diffusion, showing diffusion restriction in the peripheral part. And contrast I will show subsequently. Swan contrast showing minimal contrast enhancement on the here in this particular area. So what is it? Maybe glioma, we don't know. We send the patient for a stereotaxy biopsy, the result has not yet come. So the idea is not to find out what the nature of the lesion is, to the phenomenologically how the patient presents with acute onset of weakness of the left hand with abnormal posturing, producing a confused clinical picture. So any questions in that patient?
Sir, is it a all gliosis and which has manifested now?
Yeah, that's a possibility you have to keep in mind. That's why, in fact, I had to keep that possibility. But the weaknesses came so abruptly because it's perfectly altering 3 days back. If it is a gliotic lesion, the dystonia come later on, but not the weakness. You got the point. Dystonia, I can months and years later can manifest acutely due to old lesion, but weakness will not occur immediately. Secondly, the radiologist telling that it's not an old gliotic lesion because it's got a peripheral contrast enhancement and diffusion restriction.
Sir, one doubt, sir.
Yep.
Sir, if this is a old gliosis, so need not that have a evidence of volume loss radiologically? No need.
Yeah, there should be a volume loss also, correct. But there is some suspicion of there's no mass effect as such. But you can put the other way around, there's also no mass effect.
Okay.
Sir, one doubt, sir. So regarding that first case, sir, just asking if the bleed was on the right side, would we get so many findings, sir? That temporal bleed, no, sir, he had that.
Not on the right side, left side, I mean.
No, if it had been on right side, because I missed a patient with the right-sided bleeds. I was asking if the bleed was on the right side, would we get so much florid findings like you had? Won't get, no?
No, you won't get on the right side because he has got a visual agnosia. To produce visual agnosia, it should be on the left side.
Left side. Okay.
But it's a semantic category, but temporal lobe is also affected.
Temporal also on the left itself is needed, no, sir?
Left itself is needed.
Oh, okay, sir. That is it.
Sir, in the last case, can we just tell that this could be something like a DRD? Because in DRD also you get some pyramidal, sort of weakness.
No, they won't have weakness. DRD, they will never produce weakness. They can have mimic a pyramid. They don't have pyramidal signs as well. They can have mimic a pyramidal lesion because of the stiffness of the nerves.
Okay, sir.
Typically, there are DRDs of not the classical one. There are autosomal recessive type of GRD like many other type Dopa responsive dystonias, the septiaterin deficiencies, tyrosine hydroxylase deficiencies, and some other enzyme deficiencies can all produce. They can produce associated neurological deficit. Not only Dopa responsive dystonia, they can have pyramidal sign, they can have mental retardation, other involuntary movements all can describe. Seizures also can also occur. But they are not true classical DRD. The classical DRD of a GTP1 hydroxylase deficiency, they don't have pyramidal signs. Only dystonia can have stiffness mimicking a pyramidal lesion.
Okay, sir. Okay, sir.
So clinically, where do you localize this left hand weakness, sir? By clinically?
We know it's a pyramidal lesion is there on the right side.
No, sir, in the basal ganglion or the cortex or.
Ideally, it should be in the cortical level. This should be, if you get only hand weakness to present with, you have to think of a cortical lesion first. But sometimes can also occur subcortical lesion depending upon which part is affected.
So here the antelimb of the internal capsule is involved, then there is a selective weakness of only extensors compared to flexors. How can you explain, sir?
No. Here what is happening is the limb is also not only antelimb. Antelimb alone will not produce any pyramidal weakness. It should extend to the genu or the antelimb or the anterior part of the posterior limb. Now, any pyramidal lesion anywhere, you have to think about the most vulnerable part. In the upper limb pyramidal lesion, the most vulnerable, the earliest affection will be the small muscles of the fingers as well as the finger extensors. That's the first thing to be affected in a pyramidal lesion of the upper limb. Then comes the deltoid. So that pattern can go with that. That is a pyramidal lesion at the cortical level. They can present with only finger drop, can only present with thumb weakness. I had shown previously a case of only thumb weakness due to a cortical lesion. That is well known, but usually described in a cortical lesion rather than in a subcortical lesion like this. That is the interesting part of the part in this particular case. Very many atypical findings are there.
Sir, this case, is it something like some cystic form of glioma?
Yeah, so some kind of cystic glioma, yeah, that's the thing. That's a possibility we are keeping in mind.
So the other patient, how do you check tibialis anterior inversion in dorsiflexion or plantar flexion?
Dorsiflexion. Tibialis anterior.
If you do it in dorsiflexion, the tibialis anterior is shortened, no? So it's in a positional disadvantage, no?
We check what we do is to keep the angle in the dorsiflexion inverted position and ask the patient to break it.
Dorsiflex ചെയ്ത് കഴിഞ്ഞാൽ tibialis anterior ഒരു disadvantage പൊസിഷനിലായില്ലേ അപ്പോൾ?
What you said is correct, but in that the position, to keep that position, tibialis anterior has to contract. So you keep that position, ask to break it. That's what we do. So for example, if you want to check the biceps, you keep the biceps flexed. Ask him to keep it flexed and you break it. Same as this thing. But if you say it's keeping it flexed, then it is a disadvantage position. Yes, but you are making the muscle contract. You are not passively making it flexed. That's a different thing.
Okay.
When you passively make it dorsiflex, then it will be you are relaxing it. You are not passively making it. You are making the patient put the limb in that position. That is done by the contraction of the muscle.
Sir, in this case, when we check for the dorsiflexion, normally we look for the extensor, the digitorum as well as the EHL. So the TA also comes there, no? So usually.
No, the dorsiflexion both will come. All the muscles will put in ordinary dorsiflexion. But tibialis anterior is a dorsiflexion inverted in the dorsiflexed position. So you have to keep the limb in that position and then ask to break. Suppose you check the inversion, the plantar flexed position, you are not checking the tibialis anterior. You are checking the tibialis posterior and the flexor digitorum longus and flexor digitorum, flexor hallucis longus. They are all inverted in the plantar flexed position. So you keep the foot in the plantar flexed position and then invert. Keep it inverted and you break. Tibialis anterior, you keep the foot in the dorsiflex position in an inverted position, break it.
Okay, sir.
Okay, shall we close it today? We already exceeded 10 minutes.
Thank you, sir.
Thank you very much, sir.
Thank you.
Great case, sir.
Thank you, Carl. Thank you, Butch.